Good evening. We are here for the joint e-seminar of the Young Nephrologist platform of the European Renal Association and Young Internists of the European Federation of Internal Medicine. Today, our topic will be the cardiorenal syndrome perspectives from nephrology and internal medicine. We have a young but distinguished faculty among us, and I will introduce them one by one. Alberto Marra is currently an associate professor of internal medicine at Federico II University of Naples in Italy. He is the former chairman of the Young Internists of the European Federation of Internal Medicine. His main focus of interests are pulmonary hypertension, right ventricular function, heart failure, and cardiac rehabilitation. Welcome, Alberto.
Thank you.
Our second speaker is Amaryllis van Craenenbroeck. She is the tenured faculty and deputy head of the clinic at Catholic University Leuven University Hospital. Her research focuses on the underlying mechanisms of vascular dysfunction in CKD and its reversibility with exercise training. She is currently a board member of the European Renal and Cardiovascular Medicine Working Group of the ERA, and she's the president of the European Association of Rehabilitation in CKD. Welcome, Amaryllis. And our panelists are Balazs Odler and Martin Satny. Balazs is a nephrologist at the Medical University of Graz in Austria. His scope of research and activity mainly focuses on immune-mediated kidney diseases. He is the member of the national committee that generated the Austrian consensus statements for the management of systemic and immune-mediated kidney diseases, and he is currently a board member of the YMP of the ERA. And Martin Satny is an assistant professor at the First Faculty of Medicine of Charles University in Prague, Czechia, and he is mainly involved in preventive cardiology, especially in the treatment of hereditary dyslipidemias. His research interests include genetic determination of atherosclerotic cardiovascular disease and its risk factors. Welcome, Balazs and Martin. And I think we can start with the first talk, Dr. Alberto Marra from Italy. Alberto, please.
Thank you, Safak, and thank you, everybody. For me, it's a pleasure and honor to share with you this afternoon. And this is a collaboration between IFIM Young Internists and ERA, and I was former chair of the Young Internists, and at that time I tried to foster the collaboration between the internists at the young level and the other specialties of other disciplines, and I'm really happy that this is coming true. And this webinar, it's a kind of result of such idea of combining different medical specialty, and combining nephrology and internal medicine is something that probably we should be very aware of, because the connection between systemic disease and specifically as a topic of this webinar, cardiovascular disease and renal dysfunction, it's really high. This is a daily experience. I will just show you some data, epidemiological data that portray something which is actually our daily life. So the probability of heart failure in population with chronic kidney disease at different level up to dialysis and kidney transplant is something that is growing, and as much as the renal function deteriorate, this increase. And also when you pull the three big population study, Jackson heart study, cardiovascular health study, and the MISA, which is there are three huge population studies, you see that once CKD appear in the context of three different cardiovascular conditions, three big killers such heart failure, coronary heart disease, and stroke, these impact in a dramatic fraction the outcomes, especially the focus, especially it's heart failure. So the combination between heart failure and CKD is something really, really detrimental. And I'll show you one data coming out from a pooled analysis, just to give you a summary of something that it's particularly evident to our clinical practice. This is that combining 57 studies, including almost 1 million person, we found that the prevalence of chronic kidney disease in heart failure is almost 32%, which means every third patient with heart failure has a chronic kidney disease, and the prevalence of worsening renal function, it's 1 every 4 patients. And when we perform a multivariate analysis, the renal impairment, it's associated, and even worse, worsening renal failure are independently predictor of mortality. Therefore, once kidney involvement occur into the context on the natural history of heart failure, this is accelerate the progression of the disease. So this is a common problem, since if we think that in the 9 up to 15% of adults has chronic kidney disease, and heart failure is a disease which is accounts at least of 2-3% of the general population, which becomes up to 10-15% of elderly. Don't forget the thing that nowadays the real huge problem is the phenotype of heart failure with preserved ejection fraction, in which we have less therapy, less phenotypization and understanding of a disease. When these two combined, we can find that 1% almost of adults has a cardiorenal syndrome, and half of the heart failure patient, more or less, can have progression to cardiorenal syndrome, which is this is an old classification into 5 phenotypes that combined. Usually it's like the story of the egg and the chicken, which came first. We have an acute cardiorenal syndrome, which is a heart failure that results through hypoperfusion into acute kidney injury, which is typical of cardiogenic shock. We have a type 2 chronic cardiorenal syndrome, which is the chronic heart failure resulting slowly, then the acute form into the CKD. On the other hand, we can have the acute renocardiac syndrome or chronic renocardiac syndrome, which is the overload due to the kidney failure, respectively in the acute fashion and the chronic fashion, resulting into chronic heart failure in the setting of the volume overload or the inflammatory surge, or in case of CKD associated cardiomyopathy, which culminate into left ventricular hypertrophy. Or the fifth, which is something that can happen usually in the context of internal medicine world, which is a systemic disease like liver cirrhosis or septic shock that culminate into the failure of the 2 organs, and I would say in the context of multi-organ failure. And listing all the components of the pathophysiology of such interplay between the cardiac insult and the acute kidney injury will be sometimes something endless, because there are so many pathways that interact between the two system, and also other kind of communication that you can have between the two organs and multi-systemic pathway that makes the dialogue between the 2 organs very, very important. I don't want to go through the definition of worsening renal failure and acute kidney insult, because this is changed according to guidelines and change according also the main biomarker used. I just want to say that diagnosis usually rely on creatinine and eGFR that we can estimate through creatinine assessment. The problem is that when we want to go deeper into the diagnosis of chronic renal failure in the context of cardiac dysfunction, we should look at also other biomarkers such as cystatin C, which is a bit less dependent on muscle mass, or we should collect urine sample regarding urinary sodium, proteinuria, hematuria, and also blood gas analysis. Also, it's important also the structural Doppler renal ultrasound, but it's important also to look at some parameters of cardiac failure, and I will say something that is even beyond the ejection fraction. So nowadays it's not more sufficient that any kind of physician look only at ejection fraction. We have to look at left atrial sides, to look to something that is something I particularly interested, which are pulmonary pressure assessment, diastolic dysfunction, and other biomarker. Also in this case, not only NT-proBNP, but look also at CA 125, which is an important biomarker of renal failure. What's another problem is, and as a typical situation in internal medicine, happens when a patient is admitted to internal medicine ward for a heart failure, and there is signs of congestion, and usually internists or general physician a little bit have fear about the dip in creatinine that you can have after introducing and starting diuretics, which is typical of starting intravenous diuretics. This is a post-hoc analysis of a very important trial, which is the dose trial, where higher doses of diuretic were compared with standard diuretic. And what was observed that initial rise in creatinine after the initiation of a diuretic, so as initial deterioration of renal failure after starting a diuretic, is paradoxically associated in the long term into a prognosis benefit. So when the creatinine start to rise after initiation of therapy, it's something positive. And the same was observed also when we use SGLT2 inhibitor, which are some, let's say, something like the link between the heart failure and the renal failure, as we already are aware. And in this context, I won't be go too much into, because it will be covered by the next talk. Don't forget also to assess albuminur creatininur ratio, which is an important biomarker of renal damage. When we have to initiate and assess and manage chronic cardiorenal syndrome in the context of heart failure, HPF, we have to take care at the first instance of congestion, so considering urine and sodium output when you start diuretic, and also supporting measure like oxygen, ventilation, understand the need eventually of inotropes and invasive monitoring, and also try to obtain a good balance between diuresis and hypoperfusion. Usually cardiology are keen to increase that much diuretics and forgetting a little bit about the balance between normovolemia, hypovolemia, and hypervolemia. And another things that we have to take into account is the effect on drugs in different kind of renal failure. Diuretics are the more used, but don't forget also ARNI as inhibitors, angiotensin receptor antagonist. And the problem that we are facing is that when we start in stable patients up to KDIGO renal failure stage up to 3A, 3B, usually we don't have problem in managing drugs. The problem starts when the patients are going up to KD stage 4 or stage 5, and in that frame of renal function, actually we don't have any kind of evidence of which drugs we want to use, and also this will be covered by Amaryllis after me. Just a few words about pulmonary hypertension, which is can be on one side a complication of heart failure, and also of respiratory disease such COPD or interstitial lung disease, but also from chronic thromboembolic disease. But don't forget that this is a rare form of pulmonary hypertension, which is really rare, which is the group 1 pulmonary hypertension, which is hallmarked by a pulmonary vascular disease. So pulmonary arterial hypertension, which is the first, the only kind of pulmonary hypertension in which we have targeted therapy. And also in this case, patients with renal failure can have in somehow pulmonary hypertension for different cause. And the problem that we have to face is that drugs for pulmonary arterial hypertension can improve renal function, but also, and they can use only in group 1 pulmonary hypertension, but don't forget that we have other causes of pulmonary hypertension that can suffer from a renal failure. I make just one example. Consider the thromboembolic pulmonary hypertension, where we have to manage anticoagulation, and anticoagulation and renal failure sometimes needs to be considered together. Of course, how to manage, it's very hard, and as I say before, we don't have any evidence for advanced renal failure. Consider that vericiguat, which can be considered somehow the 5th pillar of heart failure, especially in those patients with a worsening heart failure, is a drug that can have beneficial effect when the eGFR is between 30 and 15. Anyway, in any case, we don't have any kind of evidence when we are under 15. What we can do, or what is arising? The story, we are probably just at the beginning of the path, because we have a class of drugs which are MRA, mineral corticoreceptor antagonists, which are a little bit underused in patients with heart failure. Those are data that I show you from the Swedish heart failure led by my friend Gianluigi Savarese in Stockholm. And Gianluigi was able, with this group, was able to demonstrate that MRA are underprescribed in heart failure, but they are not associated with higher risk of renal event and all-cause mortality, morbidity across the entire EGR spectrum. And they are, as Gianluigi also demonstrated, associated with underprescription that sometimes is mainly driven by the renal failure. This is the story with the usual steroidal MRA. Nowadays, we are starting a little bit to look at another kind of MRA, which are the non-steroidal, that has a higher affinity for the MR receptor. And this is the case of usually finerenone, which is a drug that is entering now into the clinical arena. This is the Fidelity, which is the pooled analysis of 2 trials, Figaro and Fidelio, that involve patients with type 2 diabetes and chronic kidney disease without heart failure. And this trial were able to demonstrate how finerenone is really effective in improving a composite of cardiovascular outcome and kidney outcome. And also we have fine arts heart failure, which are another trial with investigate the effect of finerenone in patients with heart failure with preserved ejection fraction. And also in this case, finerenone was really good in improving outcome of this patient. So I go to the conclusion. So we should be aware of the interplay between heart and kidney that culminates in the cardiorenal syndrome, which is a condition which is burned by poorer outcomes. And we have the classification in 5 phenotypes. Its pathophysiology is really complex. Diagnosing and understanding requires a deeper evaluation rather than simple creatinine assessment. SGL2 could be something like the key management of the 2 condition as a shared condition, and we are looking to finerenone with lots of hope, and could be probably a future therapy also in this kind of patients. I thank you really much for your attention, and I hope that this connection and collaboration between internists and nephrologists will start from today up to the future. Thank you for your attention.
Thank you, Alberto, for this very nice presentation. And now for the nephrology perspective, Amaryllis van Craenenbroeck from Belgium.
Hi, everyone. It's really an honor and pleasure to be here and to guide you into some nephrologist insights. First of all, I want to stress that treating a patient with a cardiorenal syndrome is something we have to do together. And we have to acknowledge that we have different backgrounds as cardiologists, as internal medicine specialists, or as nephrologists, but we have the common goal, and this is to make our patient better. Some definitions, some pathophysiological insight, and some management strategies I will share with you in the next 15 minutes. And this one is the old and the well-known definition of cardiorenal syndrome, which is any acute or chronic problem in the heart or kidneys resulting in an acute or chronic problem of the other. So it's true that this vision is a little bit chronological, like my colleague already told us, the chicken or the egg. But I want to see it broader. And recently, a new term was introduced, which is nephrocardiology, and which states that any nephrological case can also have a cardiovascular component and the other way around. So the cardiorenal syndrome is just a part of nephrology and cardiovascular medicine coming together. I won't dive into details of this slide, but I will stress that for the following of the presentation, I will mainly touch upon type 1 cardiorenal syndrome, which is a cardial decompensation. So not only the acute coronary syndrome like my colleague presented, but broader cardiac decompensation resulting in acute kidney injury. Not only nephrocardiology is a new topic, but also the cardiologist came with another term, which is the chronic cardiovascular kidney disorder. No, it actually was presented by a nephrologist, Carmine Zoccali, which means, again, that everything is both nephrology and cardiology. And you have to have at least one cardiovascular component, which can be very broad. So you can have only the elevation of some cardiac biomarkers, you can have vascular disease biomarkers, but you also have to have kidney disease, and this is defined by an eGFR less than 60 and or proteinuria, like we know it now. There is a pitfall here because you saw in the table that an elevation of NT-proBNP can also count as a cardiac biomarker. But is this really true? And this is already very old data dating back from almost 20 years ago. And there is a difference between BNP and NT-proBNP, and I know that guidelines or that practices among countries can differ, can vary. And in Belgium, for example, we measure NT-proBNP very regularly, although it's not reimbursed. But we have to acknowledge that the main clearance of NT-proBNP is renal, which means, of course, that if you see an increase in NT-proBNP, that it can be the reflection of a worse kidney function. And this is less true for BNP. So this is really something we have to take into account when we are looking into biomarkers, serum biomarkers, that we really have to take into account whether the molecule is cleared renally or metabolized in another way. And then this is a new term proposed by the cardiologist, by the president of the American Heart Association in 2024. And there, chronic kidney disease is seen as a risk factor for this syndrome, which is a syndrome, and that we have to do everything to lower the risk factors. So this all comes together, and I have to say also here that metabolic syndrome, they both count diabetes and obesity. For a nephrologist in me, some pathophysiological insights for cardiorenal syndrome type 1, well, everything or increased venous pressure is a sine qua non for this type of cardiorenal syndrome. But it's very important to acknowledge that if we are looking here into this overview of the pathophysiology of this type of cardiorenal syndrome, we see that there are a lot of reversible components. So in our treatment, we will have to try to address them. And this means that we have to try to get euvolemia as soon as possible, of course. So to work against this increased venous pressure. But also we can use beta blockers, sympathetic activation, RAS inhibitors, and this is all well known, but we really have to try to focus on the treatment targets which are still reversible. And this is a very nice overview, I think, of the role of venous congestion in the pathophysiology of cardiorenal syndrome type 1, as it both influences the interstitial pressure, and this is quite new. We didn't realize before that also the interstitial pressure is important in this sodium and water congestion and reabsorption problem. So you see here that as a consequence of the increased interstitial pressure, in the end you get more sodium and chloride reabsorption, which means that your patients will be more congested. Again, some management strategies on this type 1 cardiorenal syndrome. Well, as already told you, it's to reach euvolemia as soon as possible. We need some definitions here, and I will focus on how to measure it, how to achieve it, and what if we don't achieve euvolemia in our decompensated patients. So what is euvolemia? Well, there is a definition of it, but it's very hard to quantify. And it's important to know, as nephrologists, as cardiologists, as internal medicine specialists, that it's not solely measured in one parameter. So we have to look into different clinical signs, which can be hypotomegaly, for example, edema, of course, some functional tests, such as a 6-minute walk test, and we can also make use of some technical evaluations. But there is no gold truth here in the assessment of the euvolemia in the patient. But what's most important for you is that there is no role for serum creatinine or sodium when you are assessing a patient for euvolemia. And if I'm working on the ward, then fellows tend to say to me, yes, we now see a rise in creatinine, so it means that the patient has got enough of diuretic, so we can stop then because we reached euvolemia. So no room for creatinine in the assessment of euvolemia in patients. A short word on diuretics, because I think you're all familiar with their working mechanisms, of course, but it's important to realize that sodium is the currency of the body, and where sodium goes, water will follow. So that means that most reabsorption of water will be in the proximal convoluted tubule, followed by the loop of Henle, the distal convoluted tubule, and the ductus colligentis. As you know, both acetazolamide and SGLT2 inhibitors work very proximal, loop diuretics more distal, of course, and they do have a negative side, and that's because of a blockade of the reabsorption of sodium chloride. The tubuloglomerular feedback is disrupted, and it means that the disadvantage of giving loop diuretics is that it might stimulate again more the RAS system, but you all know that, I'm confident. Then about the potassium sparing diuretics, they work more distal, as you know, and also the MRAs, non-steroidal or steroidal, work also very distal in the glomerulus. If you're treating a patient with decongestion with hypervolemia, then you have to realize that most diuretics, if not all, bind to serum albumin for distribution. And this has consequences for your patient, especially when they're nephrotic, for example, because they really have to bind to albumin. There has to be enough albumin to get into the tubules in the end. So they have to be in tubules to have their function established. A word about loop diuretics. We prefer to use bumetanide in acute decompensated patients because it's not renally cleared. It's also metabolized by the liver, which means that there is less toxicity in higher doses. And again, because all loop diuretics have virtually all a very short half-time, you have to give it repeatedly over the day. But you know all this. So what's diuretic resistance? So what if your patient doesn't respond to your treatment with loop diuretics? And there is some fancy definition about it, but I think the most easy one to use in the clinic is when the sodium urine output does not increase after 1 to 2 hours after the administration of a loop diuretic. You can have diuretic resistance and you have to go to other levels with diuretics. Some culprits for diuretic resistance are, of course, one, the elephant in the room. You have to check whether your patients are really taking their medication, if they're not taking excess salt intake, because then an excessive output of sodium is because of the excessive increase, of course. Then you have to make sure that the drug is coming into the tubular lumen, which is sometimes difficult in hypoalbuminia, as I already stated, when there is gut edema, or when you have your dose is too low, very simple. And then you have in chronic kidney disease also the problem of the tubal transport inhibition, where the organic anion transporter is competing for the loop diuretics to bring it into the tubular lumen with, for example, uremic anions such as paratrysyl sulfate. So we really have to know that our CKD patients who are uremic probably need more loop diuretics than their counterparts because of this mechanism, but also because of the less nephron mass they have. And then, of course, and this is the case in cardiorenal syndrome type 1, if you have a decreased kidney perfusion with an increase in central venous pressure, you might also have less administration of your diuretics into the tubular lumen. What happens on the long term? Well, you risk that you can have post-diuretic sodium retention and the breaking phenomenon, which means that in the beginning you have a response to diuretics, but it tends to decrease over the days. But you have to know that this syndrome was mainly studied in healthy volunteers and not yet in patients with heart failure. Okay, I'm going a little bit quicker now. Well, I think what really we have to know is how to overcome diuretic resistance. Of course, we have to increase the efficacy by, for example, by giving more, by optimizing the dose. We can give them serial sequential nephron blockade. You also can have forced diuresis. Chloride repletion is also something you can use. You can use aquaretics, which are not diuretics, but only the free water. And there's also some studies about ultrafiltration, not dialysis, but only ultrafiltration by the dialysis technique. The American and also the European Heart Association tend to like urinary spot sodium for their guidance on diuretics in patients with cardiorenal syndrome type 1. And this means that whenever you have an hypervolemic patients, you give them more diuretics than they're used to know, and then you follow the urinary sodium. After 1 to 2 hours, you measure whether they are higher than 50 to 70. If yes, okay, you can repeat the dose until the patient is euvolemic. You can not only look at the sodium, but also at the urinary output strategy and follow very closely the diuresis of your patient. Whenever 2 of the orange clinical cases are true, you have to increase diuretic dose, of course, or you have to add some other diuretics. For example, thiazide chlorthalidone is most used in our hospital, or you can also, if not present already, acetazolamide or amiloride or something else. What I want to stress as a nephrologist here is that this is very nice, conceptual, but we have to acknowledge that in patients with acute tubular necrosis, for example, patients admitted with a high CRP, with an infection with something else, they are given contrast, that we already see an increase in sodium because of the fact that the proximal tubule is not working properly anymore. So this technique is very nice in concept, and I think it's it's true for patients with a normal kidney function, but again, in patients with chronic kidney disease or with severe chronic kidney disease, you have to interpret these with caution, and it might be safer to look at the urinary output than the potassium alone. Just a very short word about general cardiorenal protection. Acknowledge that half of the patients with chronic kidney disease that's attributable to diabetes. So we also have to take that into account, that the therapy for diabetes is also very important. And as nephrologists, we like slopes. Slopes of the eGFR, which are currently used also in clinical studies, but don't forget about the proteinuria. As patients with high proteinuria, and this slide is old but very well known. So you see that patients with high proteinuria are orange or even red, regardless of their stage of chronic kidney disease, and that they tend to have a higher cardiovascular risk, even mortality, and also other outpoints such as the progression to acute kidney injury and the progression to end-stage kidney disease. In my impression, cardiologists like recommendation. We also do as nephrologists. They like very structured recommendations. They like 4 pillars or even 5. And that's what we tend to suggest also in chronic kidney disease, especially in patients with diabetes, to give RAS inhibitors, SGLT2 inhibitors, MRAs, and even GLP-1 receptor agonists with the recent studies. And this also is reflected in our guidelines, which are very much alike. Then I just give the example of the HFrEF management strategies here. I even don't show the HFpEF strategies because they're all similar. We have MRAs, we have RAS inhibitors, we have diuretics, and as my colleague already told us, we have also SGLT2 inhibitors. The difference between cardiologists and nephrologists is that cardiologists want to give it all at once, where as nephrologists we are a bit more cautious because we have the experience of RAS inhibitors that they can give hyperkalemia. And I have to be honest that with SGLT2 inhibitors we expect a drop in creatinine, but we are not that worried because we know that this will not result in hyperkalemia, which is different in the RAS blockers, of course. And then to end, this was already touched by my colleague. We see that for patients with chronic kidney disease stage 4 to 5, the evidence is less strong for clinical trials on hard endpoints, and we really have to look case by case on patients to start whether or not with some medications. But which is even more important, we have to make sure that we invest time and resources in more clinical trials to also gather data in patients with end-stage kidney disease. Main bottom message of this presentation was that we really have to work together to treat the patients with this complex disorder. Thank you very much for your attention.
Thank you, Amaryllis, for this very nice overview as a nephrologist. And now we can move to discussion. We had some questions on the issue, and I want to start with the angiotensin receptor and neprilysin inhibitors. We have 2 questions for that, so I will combine them. First, at what stage of eGFR should we start angiotensin receptor and neprilysin inhibitors for patients with heart failure and renal failure? And the second question is, can the sacubitril/valsartan combination be continued up to CKD G5, dialysis dependent or dialysis non-dependent? I think we can start with the speakers first, then we can hear the insights of our panelists. Amaryllis, would you like to start?
Yes, thank you. Well, when to start? I think it depends on the patient, and whenever the potassium would allow for it, I would try to start it. When to stop? Well, again, if the potassium allows it and you're reaching dialysis, then I don't see a reason to stop the ARNI therapy again. But of course, this should be guided case per case, and it also depends on how the patient reacts with his blood pressure, for example. So I would take it very individual And I don't think there are good recommendations for this because we are lacking evidence there.
Well, probably the question should be turned the other way around, because usually a patient is diagnosed with heart failure, and probably the hospitalization is driven by heart failure. And then once the diagnosis is made, and then we look at the biochemistry and see, okay, can we start ARNI or not? The point is that also the initiation of ARNI should change according to renal failure. For instance, if we have a patient with stage 3, probably it's better first, in case, to withdraw any ARBs or ARSA inhibitor for at least 36 hours, 48 hours, and then start the ARNI. And of course, in patient with stage 4 or 5, I don't think this is probably the best drug, although this is a great drug. Don't forget that Paradigm study was stopped for excess of benefit. Another thing I would like also to mention is that currently in Europe, we use ARNI in heart failure with reduced ejection fraction. But please don't forget that when they did the Paragon trial, which, to my humble opinion, was not designed properly. In this trial, that was designed not against placebo, but against valsartan, the ARNI was ineffective in improving the primary outcome, but was positive in female patients. So probably nowadays we are forgetting that probably even in the preserved ejection fraction, although other evidence will come soon, this drug, there's a kind of room. So in general, this is a drug that it's very powerful, but the renal function should be looked, and also potassium, also avoid hyperpotassemia, hyperkalemia in this case should be avoided.
Thank you. Balazs, and your view on this?
So thank you very much for these nice presentations. I think we got a really nice clinical overview about the management of an acute heart failure in patients with and without CKD. I think in the case of the management in patients without CKD is quite clear. And I often get a call from my colleagues because of dip or rise in creatinine after initiating loop diuretics and so on. And I think, Alberto, you touched this question. So that means if we see a dip or even increase, that's not a problem. We should have to take a look at the volume status of the patient, right? I think there is a trial, the PROTECT trial, which investigated rolophilin in heart failure patients, and they looked at different trajectories of creatinine changing after starting diuretics, and they found that actually there is no difference in the outcome if there is a rise in creatinine, or there is a sustained increase or a decrease in that. So the question will be more complicated if there is CKD, because CKD is an umbrella definition of many different underlying diseases. And the question is quite tricky and quite weird, but when do you call the nephrologist? When do you think, okay, it's too much dip or it's too much increase, and I have to talk to the colleagues?
Thank you for I think it's a question addressed to me, because Amaryllis is already a nephrologist, so I don't think she called herself.
Yeah, that's correct.
Okay, I showed the dip, and this is defined in the dose HF post-hoc analysis that I showed, and in the case of SGLT2 is defined as increase in creatinine up to 20%. So this is the cutoff that we should use according to evidence. Of course, if this 20%, it's 25, probably I will wait and see. So I will say when the creatinine will rise up to 30%. Of course, if we jump up to 50%, in this case is an acute renal failure probably starting. So in that case, I will probably be in contact with the nephrologist, but I will also try to figure out what can cause this acute renal failure beyond the SGLT2 diuretics. Probably the patient is under septic shock, so a problem of hypovolemia. So a patient has some gastrointestinal water loss. So I will start also to, as an internist and not a cardiologist, to look brighter, to look wider what's happening. So in my opinion, I will wait a little bit and then I will call the nephrologist up to 50%. After 50%, then probably the things are coming
more difficult.
more
Yeah, this is why I'm
difficult.
asking. And you are
More
coming
difficult.
to the point actually what I wanted to ask, because you know, if there is something else, a septic shock or something, that's okay. But do you measure proteinuria, for example? I mean, it will be high in most of the cases, but if there is a proteinuric, there is a nephrotic range proteinuria, for example, or there is a hematuria or something else, then we have to think into this direction as well. Do you measure, or do you think about it in your praxis as well?
We try to do proteinuria. We also use urinary spot sodium. I read some paper. I was fascinated by cystatin C because consider also one thing that we are looking things now in the increase of creatinine, but on the other hand, what's the real internal medicine patient? 80 years old, cachexia, sarcopenia, 12 up to 15, 17, 20 drugs. So the scenario is even complex if you look just at creatinine. I always do to my fellows, guys, we treat people, we don't treat numbers. So evaluate also in the context of the whole general examination. I'll drive rising creatinine, which is probably of 30%, which is accompanied by normal CRP, normal white blood counts, the patient is okay, no symptoms, pressure is okay, it's a story. A rise of 20%, 25% in a patient that start to have hyperkalemia, proteinuria, inflammation, fever, and whatsoever, it's another kind of story. So the point is always, otherwise we'll be overwhelmed by artificial intelligence that look at number and do algorithm. We are doctors, so we should combine things together.
I agree. So this is why I always say to my fellows, you have to see the patient, because in many cases, if it happens that we are just looking at the laboratory charts and we think, okay, this is a cardiorenal syndrome because there is a rise in a changing rise in creatinine or whatever. But you have to see the patient, and you have to see the symptoms. You have to see whether the patient is cahectic and so on. And so that's a very important point.
The point is that, if I may add something, that I'm happy to be among the nephrologists. My need of a nephrologist, it's not to adjust creatinine. You are more important than just creatinine handler. My problem, and call a nephrologist, is when a patient that has huge congestion and has probably diuretic resistance, even with multiple renal blockage, hypertonic solution and everything, and I cannot manage the patient. This is the point when I need a nephrologist, when I cannot solve the congestion of the patients. And in that case, creatinine plays a role, but not the pivotal role. This is my opinion. So when I have to think about ultrafiltration, when we have to manage and thinking and deciding together, me, the nephrologist, and the patients, hemodialysis, when to start. So this is the point where I love to. I have one nephrologist in my hospital, which I have always call him and talk with him very frequently, because we have almost the same shape of mind about that. So this is the way I love to interact with the nephrologist. Creatinine is just a part of the story.
I think Amaryllis, you wanted to say something.
Yeah,
so maybe
thank you. That's very nice to hear, Alberto. That you think we can we can collaborate together, and we are doing so. Do you have any experience with ultrafiltration in your center? Because there is some evidence out there, but not on the long term.
We do in my department. We have let's say intermediate intensive care, where among the physicians that works in that unit, we have 2 nephrologists. So sometimes we call them and we discuss. We also collaborate since we were all together during COVID involved in the same unit. So in some patients, I think as there is some room in some patients when to use it.
Okay.
But it's not
I
very
agree.
easy
Yeah.
to implement.
No, I agree. But I think it's also necessary there that we start to gather strong evidence that it might help. So we should really do some clinical trials there.
Absolutely.
Another question, it's out of curiosity because we like to use chlortalidone, at least in Belgium, as a step up on loop diuretics. Is it the same in your countries? Or which one do you use as a second
Chlortalidone
step?
is a great drug. There is a great trial which was performed by internist, was published on European Journal, Chloretic trial. Juan Trullas, it's the first author, and was a positive trial. So chlortalidone, it's very, very useful. It's among the drug. Another drugs, and is a drug on another trial made by Wilfred Mullens, which is
I know.
azotamide. So this is something that probably usually internists, cardiologists are a little bit too much into furosemide fan. So they start bombing with furosemide up to the resistance, and then they forgot to probably lower dose of furosemide combined with other multiple blocking of nephron will be probably more helpful.
I just have a short comment on this. It's about the dose of chlortalidone, because we tend to use like, okay, the patient is not responsive anymore, so let's give 50 milligrams, which is way too much. I think you already are safe with 12.5 milligrams every 2 days. Then you can have an effect. So don't make it worse and try with the lowest dose. That's just a comment.
I do remember a clinical case of a patient with an HPEF with aortic stenosis and due to chlortalidone. So we were struggling to solve congestion, but we forgot that this patient could have hypomagnesemia, so low magnesium. So she started to prolong QT interval and she went to VT. So also take a look of other kind of ions, not only sodium and potassium, but chlor, magnesium, and so on.
And Martin, can we hear your views on this? And if you have questions for the speakers as well?
So all my questions were already answered. So one of my questions was when to call the nephrologist, but it was already answered. So I would like only to stress that it's important to look at this problem that all this CKD, HF, metabolic syndrome is connected. So I really like the concept of cardiorenal metabolic syndrome, which was already discussed because all these disease or risk factors have a high prevalence and also almost the same treatment. We have evidence-based medicine, RAS inhibitors, MRA, diuretics, SGLT2 inhibitors. We have also nice data for GLP-1 receptor agonists for semaglutide from the SELECT or FLOW study. And what is also important, the lipid management and lipid lowering therapies, because most people with chronic CRS are dying because of atherosclerotic cardiovascular disease. So it's important to be active. It's important to screen all the risk factors and to prevent inertia and treat the patients to prevent the chronic complication.
Okay, thank you, Martin. And we have a couple of questions from the participants, new questions. And one is about the role of urine sodium in acute tubular injury, if that is indicated or not. Amaryllis?
Yeah, I just what I'm saying is that if you're giving diuretics and you see an increase in sodium, that you have to be aware that it couldn't be it could also be loss of tubular function, so that sodium is there because it's not reabsorbed properly. And that's something else than diuretic resistance. So keep in mind that always when interpreting sodium spot urine, that they bear in mind that the tubules might be not that healthy than you expect. I hope this is an answer to the question.
Thank you. And the other question is, do you start for medication at the same time in a heart failure patient in the cardiology outpatient clinic? We do not have cardiologists here, but I think Alberto and Martin can answer this question. Alberto?
We do have evidence from the strong heart failure trial that implementing the 4-pillar as much as possible, as quick as possible, grant an improvement in clinical outcome. This is clinical trial. There's someone that used to say that clinical trial are performed on Formula One car, and in the normal street we have normal car. So of course, in a fragile patients in multi-drug treatment, and this is the internist which is speaking more than a cardiologist, it's very difficult to implement all the 4 drugs up in a row. So what I'm doing, if I have the perfect patients, 50 years old, not morbidities, lower therapy, then in this case, I can think about starting SGLT2, sacubitril valsartan, start to titrate the beta blockers, and eventually the MRA. If I have a fragile patients, the drugs that cause less side effect, in my opinion, are SGLT2, unless the patient is diabetic. And because if it's diabetic, probably I can have glycosuria, infection of the urinary tract. Beta blockers, I see if the patient is sinus rhythm, because in atrial fibrillation there's no so much evidence. MRA and sacubitril valsartan, I think about and look about which other drug is doing or not. In any case, up to 1 month, I try to put all the 4 pillars as much as I can.
Yeah, but I think we have to bear in mind, I agree with the strategy, but the SGLT2 inhibitors make sure that you also introduce the RAS inhibitors, because all data is on the combination. So sometimes doctors already feel safe when there is an SGLT2 inhibitor and they don't dare to add a RAS inhibitor. But this is just to say, don't forget it.
Absolutely. Indeed, among them, SGLT2 inhibitor are the only one that has, with the Impulse trial, the evidence that after 3 days after the admission in clinical stability, they must be implemented. So the point about the only side effect that happen, which is glycosuria and then infection, in my mind, it's up to us, to doctor, to do proper medical education among patients. If to teach patients that they have to be particularly clean and some basic instruction, we can avoid lots of infection.
Okay, thank you. Balazs and Martin, do you have anything to add before we close?
General to this topic right now with 4 pillars, I think we are a bit more cautious. So I think if we are talking about the acute setting, then we won't put all the 4 drugs at the first day after the hospitalization to the patient. We do it step by step, but I agree that we have to have all of them on the board, not only because of heart failure, but because of CKD as well, if CKD is present. Otherwise, I don't really have other comments on this topic. I think there are so many stuff that we should discuss, but I think we don't have enough time to do that.
And on behalf of the ERA-YMP and the young internists of the European Federation of Internal Medicine, I want to thank all the participants and all of our speakers and panelists for this webinar. So good evening.